My name is Ryan Gabriel, and I'm a breast radiologist at the Sarah Cannon Cancer Institute. Women should start getting mammograms starting at the age of 40. That's for the average risk woman, and there are instances when women need to get mammograms earlier than that, and that would be a conversation that would be had between the woman's primary care doctor or referring physician and the patient. On average, a woman should be getting a mammogram every year, and that's pretty standard across the board. There is no actual guideline of when women should stop having mammograms. We see women that have mammograms into their 80s and sometimes into their 90s, but really a woman should continue screening mammograms as long as she's in good health. A woman is determined to be high risk from a couple of things, and one of the most important things is getting all of their history at the time that they come into the breast center. So a woman should expect when she comes in to fill out a history sheet. And all that information gets incorporated into our electronic medical record that we have for breast imaging by the technologist. And then that actually generates a score. It's called the Tyrer-Cruzik score. And it's reported at the bottom of every mammogram report. So women who are considered above 20% are high risk generally. And at that time, that's when an additional letter would go out saying, we're identifying you as potentially high risk. A discussion between you and your provider should be had, and you may benefit from additional screening. Diagnostic mammogram is when the radiologist sees something on the screening mammogram that they want a little bit more information about. And a lot of women come in for extra pictures. They may be spot compression pictures, they could be magnification pictures, it could be an ultrasound. So at any point during that diagnostic visit, you could get extra mammogram pictures or an ultrasound, and that helps the radiologist figure out what's going on. A lot of times, and for a lot of women when they come back, the diagnostic mammogram clears up that question, and nothing additional needs to be done. During the diagnostic mammogram, if the radiologist sees something that is concerning, then the radiologist will go in and talk with the patient, describe what they're seeing, tell them what they're thinking, and whether or not a biopsy needs to be done. Because that would be the next step, is to figure out, is this something that we need to be more concerned about? Do we need to get a tissue sample of it to say, is it benign? Is it something in the middle called high risk or precancerous, or is it in fact cancer or malignancy? I got into radiology because I thought it was really interesting to see all the different structures in the body. And then from that, breast imaging was really interesting to me because not only could I see images and see the mammogram, the ultrasound, and the MRI, but I could also interact with patients and walk them through the initial steps of whether it's something to be concerned about or giving them good news that everything is fine, which happens in most cases. And for me, that is what motivates me and keeps me going every day. When I wake up, I feel happy that I'm going to work, and I feel like I can do a good service to women around the area.